Hi, everybody. It's Dr. Patricia Coughlin, and I am responding today to a request from a subscriber who wanted to know if it was safe and appropriate to treat patients with suicidal thoughts, feelings, and impulses with intensive short-term dynamic psychotherapy. So I will just start by saying it depends. So in ISTDP, we do an in-depth evaluation called a trial therapy. What research discovered actually a long time ago now, at least from the 50s and 60s at the Tavistock Clinic, is that developmental history and psychiatric diagnoses like DSM diagnoses, which are simply descriptive, are not in any way prognostic. They don't tell you, first of all, what the cause of those symptoms is, and they also can't tell you anything about what kind of treatment is indicated. So the only way to tell whether someone's going to respond to a treatment, in this case ISTDP, or not, is to do this trial therapy, expose the patient to all of the specific elements of the method, and see how they respond. It is response to intervention, not history and not DSM diagnosis, that will tell you if the person can make use of it or not. Now, I know therapists can get scared, and certainly hearing that someone is suicidal can be threatening, and there might be a tendency actually to back away, right, from really doing a good assessment of exactly what are the thoughts and fantasies. Do they have a plan? What are they thinking of doing? Who do they imagine is going to find them? These are extremely important questions to ask, and it's going to give you information about what is driving these suicidal thoughts and feelings. They tend to fall into just a couple of categories. So, and interestingly enough, the method that the person is thinking about using, or perhaps already did try, maybe you're seeing this person in the emergency room or after a suicide attempt, is related to the underlying cause. So let's look at the first one. So the first underlying cause of suicidal feelings, impulses, and despair is absolute despair, pain, grief that feels unbearable. In fact, I had a patient whose entire family was wiped out in a natural disaster. As you can imagine, the pain of that kind of devastating loss can be so overwhelming. And the thought that how could I possibly go on is understandable. So this person definitely, in the face of that, was feeling like just cashing in his chips. So there, it's not just a matter of, helping somebody grieve. I mean, that's part of it, but it's also how do you create a new life, basically? How can you find meaning and significance when your whole family is gone, right? So that's going to be one category. And people who experience overwhelming pain and grief that make it feel like they can't go on are often thinking about using pills or even getting into the car and asphyxiating themselves. It's basically going to be, let me just fall asleep and never wake up again because I'm in so much pain I can't stand it, right? So that's kind of one group. The other group is patients who are really, really angry, and that anger is getting turned back on the self. And what you'll often find in inquiry is that what precipitated their suicidal thoughts and feelings was some sort of conflict or maybe their girlfriend broke up with them or was having an affair with their best friend, and they're not allowing themselves to feel the murderous rage they have toward other people. And in the face of the anxiety and guilt about that, are turning it back on the self. So, I mean, let's remember suicide is murder, but it's just murder of the self, right? So, who did they really want to kill? And what is this both a manifestation of, but also perhaps a punishment for, right? Because the death penalty is for what, right? It's usually for murder. So again, the only way you're going to find this out, what's really motivating these thoughts and feelings, is to do this inquiry and to determine whether anger turned inward or unbearable pain is really at the bottom of it. And then there's one other category that I would say is not common, but I will never forget this. I was a resident at Northwestern's hospital in Chicago, and I was working on the adolescent unit. I had a patient who was a young girl, maybe 12 or 13, something about that, and was severely anorexic. I mean, really had been at death's door and had to be hospitalized. So I was treating her in intensive psychotherapy every day. And then one day, the psychiatrist who was the medical director and the head of the unit called a meeting in which the parents were present as well as the patient and myself. And he was doing, the interview with them. And as they all left, so my patient left to go back to the unit, the parents left, he turned to me and said, "They want her dead." So he was really picking up that she was a narcissistic injury for the parents. She had been born with some birth defects and some physical anomalies that they found quite embarrassing. And he really had the sense that she was unconsciously fulfilling their wish. And I've seen just one other case of really profound suicidal thoughts and ideation where underneath really was this identification or introjection, I should say, of a parent's wish to be rid of this child. More often, again, it's going to be, I would say most often, it's anger turned inward. And then you can also have cases where there's just overwhelming pain and grief and despair. I remember hearing about Christopher Reeves, who you may remember was a movie star, I guess you would call him. He was Superman. And he was also an avid horseman. And he was riding in some kind of steeplechase or something. The horse fell, crushed him, and he became a quadriplegic. I mean, very high injury in the neck. And his wife later revealed that he was suicidal. And he was asking her to please, pull the plug, basically. And she said, "Look, I understand how overwhelming this is and how you would just want to, exit." She said, "But it's just happened a month ago. I'm going to suggest we wait a year. If in a year from now you feel like your life is still onerous and not worth living, then I will help you." And of course, by a year, he had a completely different attitude. And that actually reminds me of some famous research on what, again, makes people happy or not. So in one case, they said, "Oh, well, winning millions of dollars in the lottery, that's going to make people happy." And so, and becoming a paraplegic would really, really make you miserable. And so they found groups for each category and followed them. And after a year, in both cases, right, whether they had won the lottery or become a paraplegic, they returned to their previous level of happiness and satisfaction. So when you're treating a patient who may be reeling from some horrible recent event, helping them remember that, they're not, this is not going to last. And don't make a permanent or come up with a permanent solution to a temporary problem. So I hope that helps you. Again, just a reminder to do that trial therapy, to be very specific about not just the symptoms, but what the precipitating incidents are that generate it, so you can get to what are those warded off feelings that are being expressed in the symptoms. And then you'll be able to tell by their response whether they're going to be able to make use of this therapy and of your help or not. So I hope that's helpful. Comments and questions are always welcome. Thanks.